Welcome everyone, and thank you so much for joining us this afternoon for Urban Indigenous Healthcare, Community Solutions to Systemic and Systematic Racism with Jocelyn Formsma. Before we go further, there are a lot of individuals and groups that made this event possible. This event has been generously co-sponsored by the Marty Center for the Public Understanding of Religion, the Posen Family Center for Human Rights, and the Center for the Study of Race, Politics, and Culture at the University of Chicago. I'm also personally grateful to the crew at the Marty Center, Tiffany Annette, the Programs and Events Manager who always calmly has a solution to all problems, Lauren Pond, the Digital Media Manager, Ben Kolek, our videographer, Emily Cruz, the Assistant Director, and especially Bree Lascota, the Executive Director of the Marty Center, who in many ways was the puppet master behind this whole event. Before we go further too, I also want to acknowledge that we inhabit, work, and study in the traditional unceded homelands of the Council of the Three Fires, the Ottawa, Ojibwe, and Potawatomi nations. Many other tribes like the Peoria and Menominee also called this area home. Due to Chicago's location at the intersection of several great waterways, the land naturally became a site which many tribes used for travel and healing before their forced removal and relocation. American Indians continue to call this area home, and Chicago is actually home to one of the largest urban indigenous communities that still practices their heritage, traditions, and care for the land and waterways. The University of Chicago community sees the importance of this land and the need for our learning and work to contribute to reconciliation and ongoing engagement with our present and our future. My name is Dr. Mark Lambert. I'm a postdoctoral teaching fellow at the University of Chicago in both the Divinity School and the college. Also a postdoc affiliate of the Center for the Study of Gender and Sexuality. This event also emerged in relation to the course I'm teaching this quarter, Indigenous Religions, Health, and Healing. But now it's a genuine privilege to introduce our guest speaker. Jocelyn Formsma is a member of the Moose Cree First Nation in Treaty Number 9 territory in Northern Ontario. She holds an Honors Bachelor of Social Science, a Juris Doctorate from the University of Ottawa, and is called to the Bar of Ontario. Ms. Formsma has over 20 years of work and volunteer experience building strong relationships and advocacy with Indigenous peoples. She has worked in areas of social justice, media, radio, film, and television, child welfare reform, youth engagement, and Indigenous children's rights with and for numerous Indigenous and First Nations organizations. Currently, Jocelyn is a board member of the Indigenous Bar Association, an advisor to the Ontario Indigenous Youth Partnership Project, and was recently appointed to the Board of Trustees of the Canadian Museum of Human Rights. Previously, Ms. Formsma served as board member and chairperson for the Aboriginal People's Television Network and board member of the National Indian Child Welfare Association. Please join me in welcoming Jocelyn. So Jocelyn, to begin our conversation this afternoon, would you be able to give us an overview of the background to and like the work that the Friendship Centers do throughout Canada and throughout this like very broad network that you have?
Sure. Hi everyone. This is nice. It's like a group space, so I'm hoping we'll have a lot more dialogue and a lot more back and forth. It's always weird listening to your own bio. It was really weird walking in and it's like my face is like on this poster and I was like, do you know how to get to this room? They're like, I'm like, yeah, yes, that's why I'm trying to get there. So, Wache Miswe, Shwebenish, Nishnakasun, Moose Cree, Nitoschin, Maika, Nototem. As mentioned from Moose Cree, I just said that my name is Jocelyn and where I'm from, and my clan is the Wolf Clan. And yeah, so maybe I'll just start with just to answer your question, you see, lawyer by practice, so I'll never answer a question like straight. I'll just kind of listen to a few things and then answer the way I want. So I had started with friendship centers like back when I was a teenager. Actually, I did my high school co-op, and for those who don't know, a friendship center is basically just an urban Indigenous, like a community center. They've become like the centers of community activity. A lot of organizing happens. They usually have some kind of hall, and the marker amongst all the friendship centers is usually like they're community driven and respond to the needs of the Indigenous communities in which they're located. So we have 130 across Canada. We're one of the largest not-for-profit networks in the country, not just Indigenous, but overall. By comparison, the YMCA Canada has about 43 members, and the YWCA Canada has like 33 members. If you're not counting things like, you know, Food Banks Canada or United Way kind of things, they're like, yeah, we're one of the largest. We serve about 1 million people every year, thousands of programs, employing thousands of people, and essentially from, you know, prenatal all the way up to lifelong care in health, education, justice, like we're touching all kinds of things. And so really, you know, we kind of come under the umbrella of friendship centers, but each one is unique to each of the communities that they serve. So yeah, I got involved about just over 20 years ago with my local friendship center, and I was recruited as a youth representative. I was about 18 years old after I finished my high school co-op. One of the board members asked me if I wanted to be their youth board representative, and like, yeah, I'm 19 years old. This sounds like something I want to spend my time on, right? No. Sitting on a board of directors is like not something typically teenagers seek out. But I was recruited, I was brought in, and I always tell this story about like one of my first board meetings. Hannah Sutherland, who was one of the board members there, had asked me to come to a meeting, and a sensitive topic came up, and they asked me to step out of the room while, you know, the adults were talking. And then she came back and got me and brought me back in the room, and she said, you know, if we're not willing to have the difficult conversations in front of our young people, how are they ever supposed to learn? And so that's something that's carried through in everything that I've done, is like engagement of young people and making sure that people have a voice in matters that affect them, whether or not we deem them like ready to participate. So yeah, in a nutshell, that's what friendship centers are. And here in the US, there's a network of urban Indigenous centers, the National Urban Indian Family Coalition, including a member right here in Chicago, which I was hoping to meet and go visit the center while I was here, but the ED was out of town, but yeah.
Okay. And I mean, especially like in the US, like I think most people think automatically of the reservation system. So like urban Indigenous sounds a bit of like an oxymoron. Like, can you explain, you know, like what you mean by that term, and also explain then some of like the unique complexities and challenges that come with working with urban Indigenous communities?
Yeah, so it sounds like, you know, pretty straightforward. Oh, we'll just have a definition, but we've actually had multiple conversations about what does it actually mean, what does urban Indigenous mean. So the short form is generally when we're talking about urban Indigenous, it's First Nations, Métis or Inuit people who, you know, for First Nations who don't live on reserve, Métis who live outside of their Métis settlement area, or Inuit who live outside of Inuit Nunangat, which is basically the territories in Canada, the far north. Sometimes it's called away from community or away from home, but we try to like stay away from that wording because for almost any city that you can think of, there are, you know, 4, 5, 6 generations of Indigenous peoples that have lived there. We often say Indigenous people belong in cities, and a lot of times cities were built on top of traditional trading posts. It was like the location for a lot of trade, or they were like, you're right on the lake, that access. So a lot of times cities were just built literally on top of like where Indigenous peoples were already meeting and gathering. So for urban Indigenous, there's a lot of we call it layered identities. So within the urban Indigenous context, there's a recognition of your own sovereignty and identity as an Indigenous person, but people have come together under different banners too. So for Two-Spirit LGBTQ+, there's usually a thriving urban community within urban communities. They find a community within that. There's people who have been displaced, whether it's through environmental issues, that there's extraction happening on their lands. They've been forced to move to the city due to lack of things like housing, healthcare, employment opportunities in their home territories. So they're actually pushed to move to the urban spaces. Or in relevance to healthcare system, a lot of times due to lack of healthcare provided on reserve or in the north or in rural areas, Indigenous peoples are forced to come to cities to access specialized healthcare. So that just kind of gives, I'm hoping, a little bit of a flavor of the complexities around these identities, right? And not everybody fits into this one box of, oh, you're an American Indian, or you're Indigenous, you're this. It's something we've tried to capture of a common experience living in an urban space, but within that, recognizing there's diversities within those identities.
And one of the things that you several of the documents that the friendship centers have put out, especially on the issue of healthcare, one of the phrases that really stood out to me that you use over and over is the status of being squeezed by both sides as the kind of unique challenge facing urban Indigenous communities. Can you explain what you mean by that?
Yeah, I think a lot of it boils down to what I call jurisdictional wrangling. So it's similar within the US too, but this idea of division of federal responsibilities and provincial responsibilities or state responsibilities here. Urban Indigenous kind of falls into that gap, right? So you've got an increase. For Indigenous peoples, we make up now the majority. So the Indigenous peoples living on, First Nations on reserve, is actually the minority of the Indigenous experience now. But the resources aren't concentrated in the urban spaces. And for urban Indigenous organizations, they're left to meet a growing demand and a growing need from the communities that they serve. But at the same time, the resources don't match their ability to meet those community needs. So the jurisdictional wrangling, at least in the Canadian Constitution, there's a specific section that says the federal government is responsible for, and this is their term, Indians and lands reserved for the Indians. But yet things like healthcare, justice, education, everything that I mentioned before, social services, they all fall under provincial responsibility. So when it comes to an Indigenous person who is not on lands reserved for the Indians and accessing typically provincially provided healthcare services, each level of government ends up pointing at the other saying, no, this is your responsibility, this is your responsibility. Whereas for anybody who's involved or knows the relationship between the federal government here in the States, typically anytime the federal government tries to overstep their powers within the state level, the state, is pretty quick to, hey, you get back over to your side. But when it comes to urban Indigenous, each government level is moving away from it. Nobody's really fully claiming that space. And so it's creating the gap. So when I say they're kind of squeezed from both sides, it's the rising demand, but the lack of resources just limits the ability for urban Indigenous organizations to serve.
Okay. Well, what have, like, in terms of either like laying out further some of like the challenges that you see in like healthcare, or at least like some of like the solutions, like, I mean, like clearly like they go hand in hand. What have been some of like the strategies and like the approaches that the friendship centers have begun taking?
Yeah, so I mean, to their credit, the federal government has kind of said, okay, we need to unpack what does addressing. First of all, there's a recognition that there's anti-Indigenous racism in healthcare, which I think that alone is like is strides, right? Even just understanding, okay, there's an issue here that's worth exploring. And so we've been involved with sort of this group of federal government, but provincial governments, representatives from different Indigenous organizations to actually like unpack what do we mean by anti-Indigenous racism, and then secondly, how do we address it? There's healthcare legislation right now that's being drafted around recognizing distinctions within Indigenous peoples. It's called distinctions-based healthcare, which just basically means like, you know, it's not a one-size-fits-all approach, but you really have to look at the diversity of Indigenous peoples to really meet the healthcare needs. And then we've done our own work. So we've did a number of webinars, and we developed our own report looking at unpacking what does this landscape look like, but then looking at what are friendship centers actually doing in this space. And we found there's a number of different ways that friendship centers are addressing the need for better and less racist healthcare. So a lot of friendship centers already provide like prevention, so diabetes education, healthy babies, healthy children, prenatal health, and like, you know, those kinds of family sort of prevention. Here's some information to help you stay healthier. And then post-care and partnering to do cultural care. So one example is like I know of a cultural coordinator who was working out of a friendship center. He's getting called because a family is in distress. One of the young people in the family had expressed suicidal ideation. Sorry, I should have mentioned a trigger warning for that. But they had actually gone and provided cultural support for that family, right? And like trying to talk through and making sure that that person felt safe and that they had what they needed to carry on. And then they went over to a hospital to provide some counseling for a family that was facing end-of-life care for one of their family members, and just offering teachings and holding space for that family to, like, you know, talk with their loved one and what is this going to mean for us, and kind of facing realities. And then they went over to build a sweat lodge for a sweat lodge that evening for the community, right? So even though this person had really no, say, formal health training background, they were providing direct health care to the members of that community in a culturally relevant way. More on sort of the mainstream healthcare service provision, we find that a lot of Indigenous peoples, through like mistrust of the healthcare system due to sort of the past, won't willingly go and do sort of ongoing maintenance and healthcare, going to appointments and stuff like that. So a lot of friendship centers, well, I should say a lot, but we're trying to build up friendship centers that are able to provide the healthcare service themselves. So we already have one example, the Minaway Clinic in Val-d'Or, Quebec, northern Quebec, that's been operating their health clinic for 10 years. So it's actually operating out of the friendship center. It's not, you know, adding culture to an existing mainstream healthcare service. It's the other way around. It's a community-driven entity that's inviting the healthcare system into their space that is actually owned and operated by the community. So if there are any issues with any of the practitioners, there's an immediate response by the community, and they have some ownership and control over that space. We have others in major cities like Halifax or Montreal that are establishing their healthcare clinics. across Quebec, I think we're trying to get almost every single friendship center to provide some kind of direct healthcare service. In Ontario, we actually already have a network of urban Indigenous healthcare facilities. So it's one way that if we can provide the service ourselves, then we can reduce the instances and provide better healthcare overall.
And like, I mean, do you happen to like know like what the like within like the Canadian healthcare system more broadly, like how many of those like health practitioners like are Indigenous or have any kind of training in like culturally appropriate like medical care?
I think we're just scratching the surface. I think there's been a lot of awareness building, so people have a heightened awareness that this is a thing, but I don't really know to what extent we've had the full grasp on it. So it ends up kind of being practitioner by practitioner, hospital by hospital, clinic by clinic. And we actually, last year actually, the Canadian Medical Association in Canada elected for the first time ever an Indigenous person as their president. And so he's able to bring a much higher level of awareness to across, the members of the Canadian Medical Association, but then at the same time while also advocating for more inclusive healthcare and better healthcare like across the country. So I think I can't say nothing's happening, and I can't say 100% that things aren't getting better, but we still have a long, long way to go before we can say, we're actually achieving even a portion of what we're hoping to do.
Something that is also likely in the background to this is the history of the residential school systems. And I mean, I was wondering if if you could briefly speak to that in that background in Canada, but then to speak to that Canada is much further along than the US is in terms of actually having a Truth and Reconciliation Commission that has like released tangible recommendations.
In 2015, the Truth and Reconciliation Commission released its final report and calls to action. And 5 years prior, it was started. And there was at least 4 different components to the Truth and Reconciliation Commission. So this was the result of advocacy of survivors of residential schools for decades. And finally, there was just some traction. There was a federal apology from the government. They had gotten most of the churches, if not all of the churches, to also provide apologies, including the Catholic Church. And part of that was actually survivors going to visit the Pope. He apologized with them. They said, please come and apologize on Canadian soil, which he did last year. Which I think those are big steps in itself, again, like just that recognition. There's also a restitution component to it. So there was a common experience payment to all of the residential school survivors, and the opportunity for more if there was a different experience. And then the commission itself and the report out of it with the calls to action. I think one of the brilliant things that the commissioners did was they handed over. They didn't just say, like, here you go, federal government, we did our job, okay, like, good luck, implementing the recommendations. They actually turned their attention to everybody and say, like, look, guys, like, okay, yes, it was federal government that established these schools, it was these churches that ran these schools, there was rampant abuse, and that the findings of the Truth and Reconciliation Commission was that their purpose was to kill the Indian in the child. It was a form of cultural genocide, wherein you took individuals and you just stripped them all of their cultural identity and tried to assimilate them into mainstream white culture. These are the findings, like this is what was actually said out of this report. And then they took the report and they said, but despite all that, we're all implicated. We all carry forward this legacy every single day, and it happens in the education system, it happens in the justice system. We're seeing us manifest what the residential schools started. So they handed their calls to action and said, we're all implicated, you all have a role to play. Here are some calls to action that like specifically are targeted at you. And to the credit of a lot of places, like they really took up that call, and I think a lot of them are trying. Sometimes you get 5 steps ahead and you have to take 3 steps back, and you get 2 steps ahead and you have to take 1. You know, it's like it's not a linear path, but I feel like there's a lot happening from that. Yeah, I don't know if there's anything else on that I'd missed or you wanted me to elaborate on. I think here in the U.S. you're just starting on your boarding school project, and it's nowhere near as in-depth as the Truth and Reconciliation Commission was in Canada, but
Yeah. I mean, maybe like in terms of like healthcare specifically, what were some of like the findings with like either like healthcare and like the healthcare system, or like the social determinants of health, like perhaps?
from the residential schools?
Mm-hmm.
I would highly recommend anybody interested read the works of Dr. Ian Mosby. He's not Indigenous, but he's a food historian, and he looked at what had happened in the residential school. So he wrote about sort of the history of residential school, how medical experimentation of the past has really led to hesitancy, especially around COVID. There was a lot of initial hesitancy around the vaccines. That later, I think with the help of organizations like ours that helped dispel the myths and tried to get, you know, good information from Indigenous doctors saying like, you know, this is coming from our own people and it's to help our own people. But there is a lot of hesitation still and mistrust of the healthcare systems because of documented racism for millennia. Dr. Mosby talks about there was nutrition experimentation completed, and malnutrition was really like quite rampant amongst the residential schools, which made some of the children more susceptible to TB, to tuberculosis. And because of some of those nutrition experiments, it led to long-term health deficiencies. So higher instances or higher risk for things like type 2 diabetes and hypertension for people that actually went. So it wasn't just, you know, these schools, there was a lot of intergenerational health factors that came from those residential schools.
Yeah. Should we maybe turn it over and bring the audience into this and see what questions some of you might have?
Wondering both like what kind of religious, cultural, traditional attitudes these people might be experiencing and encountering in the community, and also on the health side, like what does access look like for things like gender affirming care or PrEP or other, you know, unique challenges that the queer community might face?
Yeah, so there's generally an understanding that a lot of Indigenous communities not only had, so the term two-spirited, typically used in a lot of Indigenous communities, but is also used in addition to, you know, lesbian, gay, trans, queer, bisexual, the terminology. So you'll find some people will fully adopt and utilize the term two-spirited, but then others are saying, well, I'm not two-spirited, I'm an Indigenous lesbian, for example. So there's generally an understanding that the members of this community existed within our communities for millennia, forever. And that generally, from my understandings, that these were actually respected people of the community, that there was an understanding that that the different expressions of gender were normalized within a lot of the communities. I'm not going to generalize for every single one. And at least like for Moose Cree, like in our language, like we actually don't have genders. People are identified by their relationships to people. So, yeah, the idea of genderizing terms in people is actually that's also been one of those aspects. So. Introduce colonization, introduce indoctrination of, say, Christian values, and just a general disruption to Indigenous governance. And a lot of Indigenous communities ended up kind of falling or adopting some of the homophobic views through those disruption, right? So. And within that, a lot of the community members, Two-Spirit, LGBTQ+, ended up being marginalized within their own communities, on reserve, in the north. And so I think now there's a bit more of a resurgence and a renaissance of those identities. But certainly within a health context, within a service context, and an urban context, that a lot of times you'll see people not feeling safe at home because of those disrupted governance systems and those imposed understandings of who they were and how they wanted to express themselves. So they fled, they left, and they would move to urban spaces and found community within the urban spaces now. Of course, this is, again, a generalization, and I'm not one to speak about anyone's individual experiences, but there certainly is, for example, with the, on another matter outside of the Truth and Reconciliation in residential schools, we also had an inquiry report on murdered and missing Indigenous women. And out of that, there is a Two-Spirit LGBTQ+ specific action plan. And I just mentioned that because within that action plan, they've actually articulated their own experiences and the ways that they've experienced violence, and their recommendations on how to address those like specific instances of violence against the members of those communities. There's another aspect to it, access. I would have to say I'm so grateful for the work of Dr. James Makokis. You seem to recognize it? No. Okay, so Dr. James Makokis, medical doctors, Cree, also Two-Spirited from Alberta in Canada. And he's been very vocal about the need for Indigenous specific trans and trans care within the medical systems. I often say availability doesn't always mean accessibility. And so I think there's this assumption that if you're in the urban space that you have accessible to you everything that might be available, or that it's appropriate and adequate, and that's not always the case. So I think we're just starting on like general awareness within the medical community, healthcare community about the specific needs for Two-Spirit LGBTQ+. But for Indigenous specific, like we're like barely even at the starting line. So there's a long way to go, but definitely I would encourage you to check out the work of Dr. James Makokis, because he's really the trailblazer in a lot of that work.
Hi, first of all, thank you so much for coming to talk to us. This is fantastic. I was just interested, you discussed the health clinics that are inside the friendship centers. I was wondering how, I guess, recruitment and development of those programs happens, and if there's ideas for bringing more Indigenous healthcare providers into those clinics, or if it's more about incorporating it simply into the space so that people are available to, I guess, become part of it.
Yeah, the capacity is huge. The capacity needs, right, for practitioners, for midwives, for nurses, nurse practitioners, doctors, specialists. So that's definitely one of those areas where we're like, we really need to keep working on that. For all of them, there's Indigenous associations, so Indigenous Physicians Association, Canadian Indigenous Nurses Association, there's an Indigenous Midwives Organization, and all of these organizations are doing amazing work. Capacity is like a component, and I don't know to what extent there's an equivalent in the US. I would assume there is, but I know there is a national association of urban and Indian healthcare centers. I don't know much about them, but I have seen that they put some reports and publications out that would better articulate like the realities here. Did I get everything? Yeah, okay. I do try to listen to the questions, but every now and then, like, my brain just is like, okay, I'm leaving you here and I'm going off on this tangent. So sometimes I can come back to it, but not always.
And I actually have a question similar on that note. So here we have, we have FQHC's federally qualified health clinics, and a lot of times they're meant to be community owned, like 51%, 49% other entities. But sometimes, local businesses get more involved, and so their efficacy decreases by a lot. So I was curious to what extent are friendship centers actually driven by the community and not, other external forces. And then also on top of that, I have a part two, but maybe I'll let you answer that first, if that's okay.
So friendship centers are wholly community owned and driven. The boards, they're autonomous. So even though we're the National Association, we're not like a franchise. Like we don't, give license. It's like, okay, you get to be a friendship center. It's actually the community that like started first and then built it and then said, hey, we want a national association to be our national voice. So they all have their own boards of directors. The boards of directors, although I wouldn't know all 130, constitutions or bylaws for those organizations, but a lot of them have stipulations in them that board of directors need to be majority Indigenous, and that the services are provided by Indigenous people. So capacity is always going to be an issue. It's sometimes hard to have 100%. I would say very few probably have 100% Indigenous staffing and volunteers, but we're from, the even thinking of starting these friendship centers, it was all community driven. And so, yeah, that's one of the things that I think makes my job easy because I don't have to make anything up, right? Like the work is just happening. It's my job to just like create the channels to hear what's happening on the ground and then amplifying that, right? And that's why, part of the reason why I wanted to come here today, it's like just an opportunity to just amplify the work that's happening on the ground. And the more I travel and the more I'm able to get out and talk to people about what we're doing, the more I'm realizing like just what a really like world-class network we really have, right? Like it's I don't know. I work for the best people. It just honestly, like these are just grassroots people that are just, they just show up every day. They just do what needs to be done and ultimately are just making sure people's basic human rights are met, like it's just food, shelter, community connection, culture, support, like, yeah.
Yeah, thank you so much. And then for part two of my question, going back to like the urban Indigenous aspect. So I think what you're getting at is that like preventative is pretty well covered, but then maybe when we get to like specialized healthcare, would you say that it's more ignored? I mean, like here for, certain, there's Medicaid and Medicare, Medicaid, which has like a laughable, dental and vision coverage, same with Medicare. So usually you only really go in until problems get so bad that it's just like managing symptoms and it's, too far gone. How is it in terms of, getting everything outside of preventative healthcare in these urban centers?
Yeah, it's an ongoing challenge, and I think that's one of the things we're trying to address. So I mentioned we're part of this group that's looking at how do we address anti-Indigenous racism, and we wanted to be specific about like the anti-Indigenous component of it, because there's a lot of different kinds of racism in healthcare, and like the one for anti-Indigenous is really specific to those histories, and so we're looking at it in a lot of different ways. There's actually 5 different areas, and it's not just like the provision of the care, there's all of these components that interweave with it, right? So one of them is like just the systems transformation as a whole, right? The funding, the recognition that Indigenous peoples can do this for themselves, the knowledge sharing, incorporating like traditional healers and teachings into healthcare itself. There's a data component. So how do we make sure that data systems are buying for Indigenous peoples? How do we ensure that Indigenous entities have access to data? How do we have like an open repository so that we can like learn from each other? There's an accountability component to it. Like if something happens, the ability for somebody to report sometimes is not available. So if somebody has a bad experience with a nurse, they might not feel comfortable in using a process to report on that. Because if it's a smaller community, it's like there's only, one person and they'll find out who it is and there could be backlash, or they don't feel like anything's going to actually come of it if that's the case, right? The enforcement of rules, so maybe those policies exist, it's just like nobody's really enforcing them. And then what legislative policy or procedure changes do we need to make to allow for those accountabilities? And then the access component, making sure there is a basic universal access, like regardless of where you reside, you should have access to a certain level, like floor of basic universal healthcare. Recognizing the diversity, nobody comes in with just like one issue, right? Like if you don't have affordable, safe housing, like that's going to affect your health. If you have a history with the child welfare system, like that's going to affect your health. Like people don't just come in with like, oh, I have a sore leg. Like it's, you kind of have to treat the whole person, right? And so the healthcare systems really aren't set up to treat the whole person, and that's why organizations like Friendship Centers, when you can actually provide a bit more of a wraparound support, as opposed to just, we're going to treat you on this one issue, but you have to go here for that issue, you have to go here for that issue. Friendship Centers can actually be like, okay, we will help you as the whole person, and then we'll bring the services to you and referrals so that you have a better outcome. And then finally, like the training and education, right? Like the ongoing training, cultural safety, cultural competency, like how do you work with different communities? How can you help the medical systems actually understand what racism can look like? Because I would say for the most part, people like don't show up to work and be like, how can I discriminate against somebody today, right? Like I think a lot of the racism is just embedded and it like manifests through ignorance. It manifests like, I would say there are a few people who are like really just outwardly racist and will say things, but I think for the most part, it's mostly people's ignorance and just feeding into kind of stereotypes that you have to kind of sort of work around. And then there's a general public awareness component to it. So yeah, I think I went on one of those tangents, and I don't know if I can come back from that, but I'm hoping I touched on most of what you were trying to get at.
Yeah, certainly. Thank you so much.
Thanks.
Just as a follow-up question to her question about like the friendship centers that provide healthcare, I'm just wondering if there's an initiative like in Canada to recruit more Indigenous people for medical education and address the barriers that they face to getting that education.
Absolutely, yeah. I wouldn't say we're 100% in it from the Friendship Center side of things, but I mentioned Indigenous Physicians Association, the Canadian Indigenous Nurses Association, the Indigenous Midwives Association. So they've been very, very active in that. So these are organizations that have incredible experience, some wonderful people, and constantly being able to recruit and retain people in the medical fields is crucial. And we really drew upon as many Indigenous doctors and nurses and nurse practitioners as we could throughout COVID to help inform our own awareness campaigns, right? Like we like most people have a healthy skepticism of government. Although I think we probably trust our government a little bit more in Canada than the US, I don't know. That would just be my guess. But we weren't just going to take people's word for it, right? Like we found, especially at the beginning of the vaccines, like people are like, what is this? Is this safe? It brought a lot of comfort when we could bring elders together to say, here's how we're navigating through this space. Indigenous doctors who knew about both traditional medicine and Western medicine to say, like, it doesn't have to be one or the other. We can actually incorporate both, and it's going to be more holistic and beneficial to people if we're actually able to combine both. Again, like, a vaccine was only ever going to do one tiny component of keeping us safe, right? There was all these other aspects, and in terms of like your spiritual health and mental wellness, and that participating in culture and ceremonies and traditions was just as important for people, in addition to, you know, the social distancing and getting a vaccine and washing your hands and all the other like public health kind of advice that we got far and wide.
Thank you.
Hi, thank you for speaking with us today. I was wondering if you could elaborate on, you mentioned within these like friendship clinics that you tend to bring specialists to patients. That is a very, I think, unusual sort of like arrangement. You wouldn't really see that in the US. So I was wondering if you could elaborate.
Yeah, it's hard to generalize again because it's really like community by community. So I had mentioned I had gone to visit the space at Native Montreal Center. So they have the space set up. And they have certain amount of equipment. So that might be a barrier like to what specialists they can bring in. If like the specialist needs some certain kind of equipment, then that might not be the right space. They might have to go and bring somebody to a different space. But where they can, you know, I think there's different ways to have that. And sorry, just as like I'm talking, I'm also thinking. So that's like leading to the hesitancy. There was the case with the, and it wasn't out of the Friendship Center specifically, although they did work with the Friendship Center closely. It's called the Adoge Clinic in Toronto. So they actually, in addition to providing the supports at the Friendship Centers themselves, they actually went and visited a lot of urban Indigenous organizations. And they actually also did home visits for people who wanted just specialized supports. And that was more like basic, right? Obviously, if you're going to a specialist, it really depends on what it is. It's not always possible for a specialist to come to a space. But I think the model generally is whatever we can provide for you on site that makes it easier for you to access health in a way that's appropriate and adequate is what they're going to be trying to do. We also have examples, say like in the Atlantic, where a lot of people have to fly in from rural and northern communities to access services within a hub, like a city. So in Newfoundland, for example, a lot of people come from northern Labrador if they fly into St. John's to get services. The Friendship Center there actually has a transportation program, a health navigation program, and a medical hostel. So they'll go pick up somebody from the airport, bring them to the hostel, where they can stay however long they need to, bring them to their appointment, make sure that they have what they need, go get their prescription filled, they can stay at the hostel, and then drive them back to the airport. So again, this is facilitating healthcare for people coming from the north, but it's also helping to reduce the incidence of racism because they'll send, if the person wants, it's all like voluntary, right? But if the person wants, they'll send a health navigator with them, right? Just to make sure they understand the information that they're receiving, make sure they're being treated properly, and if there's any recourse or anything that needs to be done or advocacy, the health navigators are there to help to just basically navigate the healthcare system so that it's not, the burden isn't on the individual. So anybody who's been involved with healthcare or had any kind of medical issues, navigating healthcare systems is like, I'm a lawyer and like it baffles my mind. Like, I thought the justice system was like, complicated. The healthcare system like blows it out of the water. It's like, it's so challenging. Yeah.
Thank you.
Thank you so much for being here today. And you've already spoken about this a little bit, just given how you've described friendship centers as being community founded, driven, and owned. But I was wondering how friendship centers, in the ones that you've worked with at least, have structured the organization to translate individual experiences of systemic oppression or anti-Indigenous racism into structural policy or advocacy in such a way that it engages the entire community and those affected rather than someone who might be an expert, right?
Yeah, I think the model generally is you have these centers and the board of directors is made up of members of the community. They have annual meetings every year where people have the opportunity to have input into the organization. And then depending on the center and depending on the topic, we'll often do sort of community outreach on different topics so they can get insight from the community on any issue that they brought up. So there's that aspect to it. We have our own process, like nationally, when we want to get a sense of like, okay, well, what's going on in this space? And that was really what we were doing with the webinars that we held on addressing racism in healthcare. And when we drafted Our Health, Our Voice report, it's on our website, the nafc.ca website. It was really important for us, again, to like create the channels to hear what's happening on the ground and amplify that. So we just invited people to come and talk about it. So we did focus groups across the country. So these are both people who work for the Friendship Center, but also our community members, and how they access it and what are the lessons we can learn from that. And then we also, with the webinars talking about how do we address racism in healthcare, people came forward and talked about the programs that they run, the people that come, what they're hearing, and then some general like reflections. Because if you can imagine, you're a receptionist at a friendship center and you're just getting these calls like, we need help with this, we need help with this. And that informs like an approach to a certain degree. It's like who comes through your doors and what are they asking for? That really helps to give a sense for the friendship centers of like, we're not equipped to deal with this because people keep coming in and asking us for this service, but we don't have it yet. And so it's either they create a program to address that need, or they have to put it on the back burner until there's resources to be able to provide that service. So it's not like a formal like, hey everybody, here's a survey and then we're going to follow through. It's like a lot of it is just in constant interaction with the community, right? And good centers that are listening are constantly responding and evolving to what those community demands and community needs are.
Could you speak a little bit to, you've already mentioned, you have a law background, and I was wondering if you could speak to how that plays into your role as executive director, but as specifically thinking about combating, anti-Indigenous discrimination.
Yeah. I try to train my staff as much as possible in everything's an argument, and to put forward, a strong argument, we need to have evidence, we need to have facts, and so it's our job to collect that evidence, collect those facts, and then package information in a way that really supports our argument, right? Like our theory of the case, our what are we trying to accomplish, and that every proposal that we write, every report that we write, every piece of communication and advocacy really needs to drive back to what is it that we're trying to achieve, and what is the outcome that we want. And we're trying to persuade government, funders, the general public to see our argument and to agree with us and to help us to achieve that outcome, right? So I say that all the time, like, I am constantly using all of the legal skills that I got, if not more than when I was practicing law, because the issues are so broad, and there are more players. And I mean, to a certain extent, you could get up in front of a judge and you could, have your argument on one case, but I feel like a lot of what we're trying to do is actually on the systemic level, right? Like, it's not just one court case is not going to necessarily, it might be a watershed, but one court case isn't necessarily going to get you the outcome that you're wanting. You need to have these other aspects to really shift like a whole system towards being more responsive and more towards justice, right, and reconciliation.
How, I guess, like climate change and just like harm to the environment plays into this. And something I've been thinking about in terms of health in our class is like how, I guess, a lot of health issues that arise in like the modern day are related to like land practices, I guess, in that like pollution can cause a lot of illness, and also like farming practices impacting the kind of food we eat. And I think about like how that also impacts Indigenous people. And it's a complicated issue, and it's a really big issue. And I guess I'm wondering like if the Friendship Center has any kind of like environmental advocacy programs or like discusses this like issue at all, and like what your perspective is on it.
Yeah, well, as I mentioned, like, nobody comes in with just like one issue, right? Like, everything's related to something, related to something else, related to something else. The environmental component, though, is really fascinating. So in my territory, where I'm from in Treaty 9, which is basically covers most of Northern Ontario, it's a landmass about the size of France, 49 First Nations communities, and the population is pretty sparse, but every single kind of industry that you can think of is present. We have electric dams, we have mineral mines, we have forestry, we have gold mines, we have diamond mines. Like, it's all there, and like the health of the people are intrinsically tied to the health of the lands, right? And so a lot of the nations there, like billions and billions of dollars worth of value is being extracted from those lands every single day, and yet those communities aren't seeing the financial benefit, which then they could put into their own housing and infrastructure and healthcare and all those kinds of things, right? Like, a lot of them have impact benefit agreements, and there's different models now being used with like development companies and First Nations, and there is a legal obligation for consultation with Indigenous communities before these developments happen. I'm getting off a little bit, but basically my point is like the health of the environment and what happens with industry absolutely affects Indigenous peoples and does relate to their health. In some places, like in South America, and I think mostly the examples I think are from South America, where Indigenous peoples, because of environmental racism, a lot of chemicals are ending up in the waters, people are getting sick, babies are being born with deformities. And actually, I shouldn't even say like South America, it's like literally happening in, what's that city? It's Not Windsor, it's up Sarnia. They call it Chemical Valley. It's where a lot of like cell phone parts are made in this like industrial area. But because they've been doing these chemical plants are basically all along the river, the First Nation that's right there has, it's actually skewed their male to female birth rate. So it's really disrupted like a lot of the health systems. Like they have puppies that are born with like 3 heads, and like fish that are, they can't eat the fish from the rivers anymore, which disrupts like traditional harvesting. And so yeah, just saying everything that you're thinking about and talking about, it's very real. What are we doing about it? Well, a lot of the discussion around environment and climate change is very sort of, I guess, on reserve focused and sort of out on the land focused. And what we're trying to do is think through, what does it mean within the urban space? So a lot of times Indigenous peoples that are living in urban spaces end up being sort of a caretaker of the lands and waters here. So ceremonies happen in parks, or they go to the riverfront. And so there's an element of caretaking there. There is also an element of like emergency management, right? So with climate change, we're seeing a lot more natural disasters. People are being displaced from where they are. And when it becomes on Indigenous lands, one of the first calls they make is to the Friendship Center saying, can you take these people in? Or can you offer some kind of support and service to these people while they're here? And it happens every year, whether it's flooding, fires, earthquake, not as much earthquakes. We don't really have many earthquakes, but we have almost every year, because of forest fires and flooding, we have Friendship Centers that have to respond to the natural environmental emergencies to serve the people, right? So, yeah, and then of course there's always like just the physical health of people who stand up for water and water rights and to protect the land, right? They're sometimes quite literally putting their bodies on the line and being physically harmed by systems. And when really they're like, we're not just protecting it for us. Like, yeah, this is our territory, but like we're protecting it for all of us. And and yet we're still being harmed in those processes. So we're not there yet, but we're like just starting to kind of like think through what is like environmental stewardship and climate change. What are the policies that would really affect us within the cities ourselves? And then, of course, there's aspects of like environmental sustainability and making sure that, you know, windows are there, looking at options for like solar panels and all those kinds of things. So they're all interweaved. We're not there yet, but we've started thinking about it. I'm hoping this is all interesting and like applicable for everybody. You never know. It took me 2 days to get here, and I'm just like, all right. I want to make sure it's useful for the folks that came.
I was curious, I know we've been talking a lot about like healthcare resources, but I was wondering if their friendship centers have like any initiatives for like educational equity for like Indigenous young adults and like teens, especially like access to higher education. That's like something I'm sort of interested in or like curious about, so I didn't know if there were any initiatives that do that or resources and how they work.
Yeah, there's a lot. I mean, right from childcare, before and after school children's programming. We have student support programs through Friendship Centers, children and youth programming. There's some Friendship Centers that will offer like alternative high schools, so they can go and complete their high school degree through the Friendship Center. We haven't gotten further than post-secondary as far as I know. We do have various First Nations or Indigenous post-secondary institutions. There's like the First Nations University in Saskatchewan. There's the Original Peoples Learning House, which that's more like outside of formal education. It's like it's more ongoing education for folks. First Nations Technical Institute, where people can actually get like degrees and that kind of thing. So we don't provide them on that level ourselves, but there are some entities that exist that do provide that kind of a service for Indigenous peoples.
Yeah, thanks so much. This has been super interesting. I was wondering about, I feel like in the US, we often think of the Canadian healthcare system as like a lot better than ours. And people talk about like, oh, I'm just going to move to Canada because I can get better healthcare there. So, but it sounds like obviously there are challenges that in the Canadian healthcare system as well. And so I guess I was wondering, like, are there particular challenges that come from a more nationalized healthcare system when it comes to, you know, advocating for healthcare equity? Or are there particular benefits that you've seen that maybe, you know, Indigenous people in the United States are not able to access because of our more fragmented and capitalistic healthcare system? So I don't know how like familiar you are with the U.S. healthcare system, so you don't have to do a compare and contrast if you don't want to. But I'm just wondering, like, from a more nationalized perspective, does that make it easier or harder to see like widespread change, I guess?
Yeah, I was mentioning there's a line from a band in Canada called the Arrogant Worms that says it's not that we're much better, it's just that we're less worse. I feel like that's kind of the same for the Canadian healthcare system. I can't say we're better, but maybe we're a little bit less worse. Like I was sharing that like it blows my mind to that costs would have to factor into whether or not I called an ambulance, or that I would be able to access like a basic level of healthcare without having to pay for it. Like that, I take that for granted, and I appreciate that. I'm glad I can take that for granted. I mean, there's a lot of I think pros and cons to the systems. I definitely would never give up what we have, and I think it can only get better. And so for all of the challenges that we face within Canadian healthcare, I think that what we have is solvable, and I think that people generally are committed to those transformations to see it work better for people and to provide a better range of healthcare. I'll give you an example. So Dr. Aliko Lafontaine is the president of the Canadian Medical Association, a friend of mine, also Indigenous, for the first time ever. And he's really pushed on this idea of like, why do we have different licensing for different provinces? Like, can we have a common licensing for practitioners so that if you're in Nova Scotia and you want to cross the border to provide service, or somebody wants to cross the border to Nova Scotia to get service, and you're from New Brunswick, but they can't because of the licensing, like it seems like a very arbitrary kind of barrier to put in front of people. Like for the most part, if you're trained anywhere in Canada, you probably have a similar basic level of training, regardless whether you're trained in BC or Ontario or Quebec or, you know, anywhere. I would say that's probably the same for the United States. Like generally your training is probably more or less the same. And so if there's arbitrary things that are like blocking people from being able to provide a service, I think it's the responsibility of governments to try to remove those barriers as much as possible, right? And that comes like a federal government can definitely play like a influential role, but if states have a lot of power, and like they can really do a lot of relationship building amongst themselves and just decide for themselves, like, we're going to pass this law. We don't really care what other folks do. And I think we see states doing that in a lot of other regards, and why couldn't they do that with respect to healthcare, right? I won't go too far down that road because I feel like we'll get into like a whole compare and contrast of US and Canada politics on a lot of different areas, which was fascinating to me. Like, I've done a little bit of work in the US with the National Indian Child Welfare Association, so I would say I'm pretty familiar to a certain extent of like general approaches, and certainly studied US constitutional law in law school, which, oh my goodness, like that's a whole, yeah, I would just say I find it all very fascinating. But at the same time, like, you also have some of the best researchers, the healthcare facilities, practitioners, like in the world here too, right? So I can't, just completely shut down the system that's here. There's elements of amazingness here, and people do come for your world-class healthcare, but I think there's a lot more that needs to be done to bring the floor of what people have access to across the board. I definitely think nobody should have to pay for unexpected healthcare emergency, and that you should not be worried about, kind of falling down outside and not wanting somebody to call an ambulance just because you're worried about how much it costs. Like, to me, that's like, I think we could probably fix that.
On that note, I am curious about your opinions on the relationship between legislative change and community-based change. You mentioned earlier the distinction-based healthcare legislation that seems to be coming into place in Canada, and I'm just curious if that's something that the Friendship Centers actively advocate for and are hoping to, create bigger reform legally, or is there a push towards more support for community-based resources?
I would say I'm always on the side of community driven resources. I think systemic change follows what's happening on the ground, and that governments move based on momentum that's happening on the ground. So if you can find a way, and this is the challenge, right? Because like you need resources to implement the thing, and then so it becomes a whole cycle. But in my experience, when communities are motivated and they find a way to make something happen, and when things are happening, it attracts resources and it attracts attention. So I'm always going to be on the side of like, put the resources into the hands of the community and then let them tell you what they did with it, as opposed to let's do this like great and wonderful study and have a research, and then we'll create an action plan, and then we'll create all these recommendations that never get implemented. Like it's reverse for me, right? Like I feel like instead of putting the resources into a study, it's like if you put the resources into community, the study or the results end up being the learnings from what's happening on the ground. And from that, I think you build the systemic change, because then people are like, what are they doing over there? Like, that sounds really cool. Like, why can't we do that here? Well, I want to do that here. And then I always say, like, one of the founders of the Friendship Center movement is we have a Senate. It's kind of like our, wisdom council, or if you will. The first Friendship Center started out of like people's kitchens, right? Like it's just like sitting down, and a lot of it was Indigenous women too, right? Like sitting down and be like, okay, what are we going to do about this thing? How are we going to do that? And if you think about these conversations that were happening in Vancouver, Winnipeg, Toronto, all having similar kinds of things, and then these centers started popping up, and they knew about each other, they heard about each other, and from those initial conversations like 70 years ago to the establishment of the NAFC 50 years ago to a place now where we have over 130 sites, like that wasn't in any report. That wasn't anything that people said, from the national level, what we need to do? It was actually the other way around. It was like all of these like locals started popping up, and then they came together and said, let's create the national to advocate on our behalf. And I kind of see that as a similar type of example, I guess, of what we can do on any issue. You have to start small. It has to be really rooted in community. But from there, and you're able to build, then you get a certain momentum that can push against the forces, because the systemic forces that exist are going to be very, they're completely enmeshed with the status quo, right? It benefits people. The systems that exist, they benefit somebody. If it didn't benefit somebody, then they wouldn't exist the way that they do, right? And it's only through demonstrating what's possible, building the momentum, and then pushing back against those forces that you actually ever see systemic change happen. At least that's the theory.
So I was just curious. We were recently talking about the American healthcare system and how there might not be a floor for what people are able to access in terms of their basic needs for healthcare. And we've talked a lot about systemic change, but I was just curious about your perspective on how individual healthcare providers or individuals working somewhere in this system can work towards health equity on like that very small scale?
I believe everybody has the circle of influence. They might not see themselves that way. And certainly being one person can feel very isolating when you're the only one that's saying like, hey, this isn't right, or hey, we need to be doing something about this. So I recognize that. And then I think you also need to layer in other ism factors, right? Like racism, sexism, you know, being a person of color trying to stand up against a whole institution. Obviously there's more risks there than for somebody who might be like white presenting or white men within a system, right? I think we have to acknowledge that there's those aspects to it. But regardless, I still feel like everybody has a circle of influence. And I think that's always an opportunity to try to reach into that circle of influence and try to build it out. So if you're one person, there are people that you work with. Some people maybe you get along with more than others. And so having an agreement among people that you know and can agree with you helps build some solidarity. If you can get the attention and the support of leadership, I think that helps too. So then if at least it's coming from the top, like, okay, we really want to address these things and this is what we're going to do about it, kind of gives the individual permission to say like, look, here are the things that you've said that you want accomplished. This piece isn't being done right now, or actually what we're doing is going against that outcome or value that you state you want. So maybe we need to address it a little bit differently. And coming to the table with ideas is always welcome. And I say that with hesitancy because I know that if you are in the middle of trying and you're that one voice trying to create the systemic change, like saying, hey, I have an idea, maybe some people might pick it up and some might just immediately quash it, right? But I think you just got to start with your circle of influence and try to build out, try to look for places and your backup, your evidence and your materials to say like, this is the right way to go. And then I think you just have to be consistent. We talked, one of the webinars that we did, we talked about what people's mechanisms were to actually address some of the systemic healthcare issues. And a lot of it, again, using like sort of legal term, but like, you know, you look at the remedy that you want. What is it that you want? Because that'll dictate the process that you engage with to get there. So if it's, we need to get this person fired, like there's probably a pretty formal process that you need to follow in order to get to that outcome, right? But if it's just like, we want to provide X service within this this healthcare space, then there's a different pathway to get to that, right? And so the mechanisms available sometimes are very formal, they're institutional, or they're within that company or that organization. Sometimes the remedies are legal, like, you know, if you can actually take something up legally, there's always that aspect. But really it depends on the situation. One of the initiatives that I wanted to talk about, we're not there yet, but it's being piloted in BC right now, is called the Safe Spaces app. And this was a way to document the experience without people feeling like they necessarily needed to follow a process. And it's for anybody, but it's by, you know, by an Indigenous organization and intended for Indigenous peoples to say, what has your experience with healthcare been? And through people telling their stories without the expectation, like, you know, anonymously and without the expectation of a remedy, we're able to collect data that then we can inform some of the broader policies. So it's being piloted out of the Friendship Centers in BC right now. We're looking at how do we launch it nationally. There is an entity in Ontario that's taking it up. And the idea is that if we start collecting information on healthcare experiences, we can start rolling up those experiences into very specific policy recommendations, and we can give that to decision makers, whether that's the provincial government, the federal government, even local hospitals or clinics, and publish it and just say, like, here's what's happening. And it's up to us to really do something about it. And even the whole, you say you want to do this, but here's the reality, like, find a way to connect those.
I have a sort of a broader question, and I've been thinking about this comment you made about like change comes from the ground up, and it's really work within the communities, and I completely agree with that. But I think there's also like a real tension between relying on the work of Indigenous women in their kitchens who are doing unpaid labor to kind of organize and create these communities, and then and asking, you know, the people who are already marginalized to do that work. And so I don't even know if I have a fully formed question, but I'm interested in like how the Centers as a nonprofit kind of deal with this tension of like being for and of and by the people, but also like sort of relying on your own
yeah, we're very tired.
labor.
We're very tired.
No, and I just like, it's something I've thought about a lot. And even as the director, as a lawyer, you could make a lot more money working in a private sector or something, you know, and just like, how do you think about that tension, and what kind of remedies might there be for that? Like, what might that look like? Just
yeah, you actually like really touched on, I've had the same conversation with the government, even just a couple weeks ago with like the Office of the Deputy Prime Minister of Canada. I said, look, you are relying on people with the least amount of agency and resources to pull governments together to try to solve this issue, and then you're relying on us to give you the recommendations, when day to day a lot of the people on the ground that are working are just getting through their day, right? Like, you never know who's going to walk through those doors. There's more work than there is people. And we're very tired. It's definitely, that's true, right? I think you really touched on something there that we struggle with. So the way that I try to take up that task is, my job with the National Association is to take on that burden for the communities, right? So again, listen to what's happening on the ground, try to roll up, try to create tools, so templates or policy papers, just kind of capturing that information, trying to get resources that help build the capacity, right? I feel like that's part of my job, and it's my job to kind of fight against the powers that be, if you will, to try to move it on behalf of those folks that are working on the ground. I figure, we can take it as a national organization, and we can wake up and do those battles. Certainly, that was like what got me out of bed during COVID, especially on the days when I really didn't want to. I'd just rather like kind of stay cozy and just like, maybe I'll just sleep a little bit longer because I'm just really like tired and depressed, and like this sucks, and like, are my friends safe, are my family safe, like when's this gonna end and what's gonna happen next, right? But I had that luxury, and I thought about all of the people working on the ground who still had to get up and provide shelter for people that otherwise wouldn't have had shelter available to them, right? That the staff of the friendship centers that like went out and they collected traditional medicines. With care, they would put these packages together, food and supplies, and would put like coloring books, like trying to think of the whole communities, right? Like I felt like they don't have that luxury to just not wake up and not provide that service to the community. They could. I mean, they could just say like, hey, we're shutting down, like, we'll get back to you when things are up and running. But by and large, most of the friendship centers opened their doors wider, right? They like had to pivot really quickly to provide service online. They were just out there doing everything that they can, and making sure that people were safer. And so it's my job, I feel like, to kind of make sure that those people have every resource that they need to do their work. But it is very true, and it's hard sometimes because you just know, like, Indigenous women know how to get things done, and those are the ones that you really want to be organizing this stuff. And at the same time, there's a recognition, like, they're not the ones that are getting the big salaries. They're not the ones that are getting even a lot of the recognition, right? But if you lose that, I also think you lose some of the legitimacy of it. So I think there's an element of solidarity. I think we saw that across a lot of communities that were kind of suffering, and people kind of like, whatever it is that we're asking for, it doesn't take away if we support you and what you need. And certainly allies help too. Dr. Ian Mosby, as I mentioned before, like, you know, he's like, I'm somebody that has a skill, and I'm here to offer that to support this work, and he's very well respected. And then there's others that have done that too, filmmakers and historians and people that have said, I have a skill set and I can help in this regard. Would that be helpful to you? And then it leaves it to the communities to say, yes, we'll take up that offer.
Well, I mean, actually, maybe on that note, as we're coming to the end of our time, you have a captive, invested audience. I mean, what would you most want us to know?
So I've used examples for across Canada, right? But you're here, and there is a community here. There's an American Indian Center here. So I just came really to provide an example of what we've done. And I mean, every day I'm faced with challenges, and I can't say that things are perfect, but I'm really proud of the work that we do, right? And I'm often careful and cautious when I come into other territories, because I know probably the similar, same struggles that we're dealing with are happening here too. So what I would say is, like, I hope this information sparks something for you, or at least gives you some examples to look to in your own career paths and your own work. But wherever you are, and wherever you find yourself working in the future or now or whatever it is, I would ask you to ask yourself a few questions about whether the work that you're doing is helpful and legitimate. Who are the decision makers? So if the decision makers aren't made up of the communities that you are trying to assist with, that should be a flag for you as to whether or not that's actually a community-driven entity and that's going to serve the purpose that you're hoping to achieve. Who makes the money? Because if you're looking and supporting an organization and the people that are making the most money are consultants or people that aren't from that community, that should also be a flag to you about what is happening within that community. Decision making, follow the money. There's one more question that I'm forgetting that I'm probably going to think of later. Yeah, totally drawing a blank on that. But essentially, the point was, like, especially if you're going to be working with Indigenous communities, a lot of people will claim to be working in the best interests, but there's a lot of people that have gotten a lot of money out of marginalized communities in the name of assisting and helping, that actually hasn't left behind a whole lot of capacity. And so I think the important models and principles is that capacity should always be built and be as much maintained within the communities that are being affected. You know, by, for, with, and if you're there to support, to make sure that you don't take up space in that leadership role and walk with humility to know that maybe I don't know everything, and that these communities know a lot about what needs to be done than I do. For any issue, for any topic, if we see the news, right, like there's this challenge and there's this challenge, and I always assume that there are people in those communities that have thought of every question that you could possibly think of, and that if they haven't been able to overcome a certain challenge, the barriers that are in front of them are probably a bit beyond anybody who's just kind of Googling things. So yeah, definitely take your cues from the communities that you find yourself working with. And I mean, I'm talking about Indigenous communities, but it really could be transferred. Like, I think those principles could be transferred to almost any community that you're working with. Like, it should be by and for. Decision making, the funds, the agency should all be within that community.
Well, thank you so much.
Thank you.